This is the Aware Families Podcast, the show that brings you a science-based, practical look at how to use the principles of functional medicine to keep your family healthy. Hi, welcome to this episode of the Aware Families Podcast. Today's special guest is Jennifer, or Jenny Kingan.
Yeah.
And she is from Healthy Beginnings, a pediatric therapy clinic in Kalispell and Columbia Falls. But we're going to be talking about all things pediatric therapy and finding out, what speech pathologists or SLP, speech language pathologists, OT, PT do for kids. And we're going to end up talking about some things like some pediatric feeding disorders and some things to watch out for if you're a parent, if you have a kid who has some feeding issues. But we'll start by just having you introduce yourself and just a quick bit about your background.
Great. Thanks, Tom. So Healthy Beginnings Pediatric Therapy, or holistic clinic. Who am I? I'm a speech language pathologist specializing in feeding disorders among a few other specialties like apraxia. I've been practicing since 2009, I think, so like 16 years. Private practice owner since 2011, and have dabbled in all the settings, but this one I love the most.
Yeah. So I guess tell people a bit about speech language pathology. I guess what drew you to it? What are things that are in that wheelhouse, in that domain? Like what kind of things do you see? What kind of things do you treat?
Yeah. So what originally drew me is my sister has cleft lip and palate, so that's what got me interested. I was like, what is speech language pathology? Was going into teaching and ended up switching gears and doing the speech language pathology path. What is speech language pathology? It can go in a million directions, but from stuttering to sounds to language, I think the biggest thing to know is it encompasses so many different parts and pieces.
Because there's the speech part of speech,
yes.
And then there's the feeding part of it that I always think of being a Pete's GI and all that. So differentiate those two areas.
Yeah, so you have your cognitive area, you have your language area. And then you have your speech sound area, you have your motor speech, which can be, more like stuttering, apraxia, a lot of different avenues.
Kids just don't speak?
Mm-hmm. Kids just don't speak. So just developing all those cognitive connections, and then pediatric feeding. So sometimes it falls in the wheelhouse of occupational therapists, but in our state, I think it just fell into the speech slap because we are most versed in the oral mechanism, so the musculature there, and of course we deal with the swallowing part of it. That is our specialty. So a lot of the texture version types of scenarios go hand in hand with just getting food into our mouth and then being able to chew it and swallow it. So
okay. And OT sounds like that can also be variables for there's different things that OT's occupational therapy. So for OT for adults, obviously different than OT for kids since they don't quite have an occupation yet. But
right.
But yeah, so how about OT for pediatric population? What kind of things do they tend to focus on?
Sure. Of course, there's the basic fine motor type of skills, but our occupational therapists specialize in sensory integration and reflex integration. So basically the fundamentals are like your business, the roots, what's the root cause of some of these developmental issues. And I think that's why occupational therapy is so important, because it's getting at those underlying causes of why are they not developing. And most times it's a sensory or reflex integration discrepancy there that we need to sort out so that the rest of the development takes off.
Which sounds like that, the sensory integration disorder, or disorders, I should say, it seems like it's a big growing area. Like it's starting to be more recognized, and obviously that's, there's a spectrum of that, and obviously there's a lot of that does seem to be tied in with autism spectrum, but it doesn't have to be. There's there's a whole grouping of them that's completely outside of that. But there seems like that you hear that more and more. I mean, that's a whole rabbit hole right there. Like why is that? Is it a recognition thing? Is it actually? And I guess what's your opinion on that? Do you think it's actually, or are you just recognizing it more? Or do you think it's actually on the increase that there's more of these sensory disorders?
Yeah, that's a little topic, but I think a combination. Obviously, our environment plays a lot in what's going on, but I think our recognition of the sensory system is increased as well. So we all have our sensory systems. It's just a matter of how we're organizing them. And so are our bodies able to organize the input that's coming in, or do we have trouble doing that, which is affecting our developmental skills? And so, like I said, I think a lot of environmental factors contribute to that for sure. But our understanding and how we're responding to those are.
And we've talked about the whole first 1,000 days concept, starting in exactly. We've talked about that on the podcast, like starting in the womb, and then going on to the first and then the second year of life, and how the brain goes from nothing to 80 to 85% of an adult size, and so all that neurodevelopment that's going on, and if there's toxic stuff in the environment or inadequate nutrition or any other host of things that could potentially affect that, I think those are all. And it's not casting blame. It's just, again, like looking for the root causes of some of these things. Exactly. And how would some of these, like, what do you see the presentation of those type of things, like the sensory disorders? Like what's, I know that's a range, but what type of things kind of come to mind as how those kids present?
Yeah, I think the biggest thing is, their misdiagnosis ADHD. And so a lot of times they're, bouncing off the walls or can't sit still or may not be able to organize. Maybe the higher functioning, so to speak, might not just be able to organize how their eyes work together to team up to write something on a piece of paper, or to be able to organize their thoughts for spelling a word. Some of those little subtleties that you're like, oh, that's just a difficulty with reading or writing, but it can be such a bigger issue if you look at the whole child instead of just the things that they're struggling with.
Mm-hmm. Yeah, and it's a complex system, yes. Right? So, and a child may have overlapping things going on too, which I think also kind of further muddies the water.
Sure does.
And then there's PT, physical therapy, that would be what kids more with, like either more motor delays or kids who might have some other congenital, whether it's CP or other.
Yeah, torticollis is a big one too for the infants. So tightening of one side of their neck, obviously, which can affect so many things, reflux to, just feeding in general, to then later, again, being able to track and spell and write, those types of things. But torticollis, orthopedic, we get a few orthopedic types of patients, a few.
Like post-injury?
Yep. Post-injury, so broken leg or, hurt their knee in sports or those type of things. General, just developmental, like learning to crawl or walk, balance issues. And then I think dabbled in a little bit of pelvic floor, so just being able to control bowels and those type of things. But though that their specialty is probably not pelvic floor, but they can do some of the basic things for sure.
Well, pelvic floor, again, I think it's become its own issue, or not issue, but like its own subspecialty that is hugely needed. And being in the GI world, it's it can be so useful. And I think the more people who find out about it and like what they do and what they can do and the things that they can help with, it's just exploding, and it's not just a female thing, and it's not just a female thing post childbirth, although I think that's a great area for pelvic PT. But the kids with some of these bedwetting or defecation disorders, or adults who have incontinence issues or things like that. There's a lot of things that pelvic PT is treating. So it's been interesting to watch that field grow over the past 10 to 15 years. But let's talk about pediatric feeding disorders, or PFD, not personal flotation devices, but the type that are, I think, also increasingly common, increasingly diagnosed, but still wicked underrecognized.
Yes, very much so.
So in your, I guess, in your purview, like what falls under pediatric feeding disorders, and what kind of stuff do you see?
Oh gosh, that's a loaded topic as well. No, but pediatric feeding disorders, kids that have a limited food repertoire and or difficulty chewing or or moving the food in their mouth to be able to swallow appropriately, or the swallowing musculature. Our kind of cutoff is 25 to 30 foods. So if they don't have 25 to 30 different foods, then that might be classified as a pediatric feeding issue.
By what? By school age, or by what age do you kind of make that cutoff?
Probably I would say by 4 at the latest. I would say is I mean, they have quite a variety of foods. Even 1-year-olds, when they're first eating, they can trial a bunch of different foods, and you can kind of see those already at that age kind of developing preferences. Now, are they developing preferences because they're picky, or is it because of some sensory or underlying issues going on?
Or mechanical issues,
Mechanical
right?
issues, yeah.
And we've certainly shared patients who ended up having EOE, or eosinophilic esophagitis, which is an allergic inflammation in the esophagus, and it hurts to swallow chewier foods. Yeah. So, and especially early on in life, these kids, they might not be able to verbalize it, but they're like, I'm not eating any chicken, or I'm not chewing this bread because it gets stuck, and then I choke and it's miserable. And so they might all of a sudden start self-restricting or remove foods from their diet, and that's based on and that's, I think, the subtlety point where it's good to have a kind of multiple eyes on it, right? Yep. Because is it behavioral? Is there something else going on that's causing the behavior? And so I think it does take that multidisciplinary approach to make sure you're not missing something or misdiagnosing something, or because how could you expect somebody to swallow something if it's getting stuck all the time? I mean, I wouldn't want to do it. So.
Exactly. And that referred sensation, they might have some issues going down on the lower part of the the esophagus, but it's sending signals back up to the throat area or the mouth area. And so even, and that's in adults as well. So it's just a different sensation, and that's how your body registers that sensation. So it's important to rule out all the medical aspects of what's going on to make sure that we're addressing each part.
But it seems like, in my experience, experienced SLPs will be able to kind of at 1,000 paces tell, this seems more behavioral, or it just really seems like there's something more going on, like a true what's called dysphagia, where there's mechanically something going on with the swallowing, whether it's getting stuck or it's painful, or there could be some kind of area in the back of the throat where there's something not working quite right, and there's, again, a whole host of things, neurologic and otherwise, that can cause difficulty in swallowing. But versus, okay, it looks like the mechanics are okay, but they're just end up being super picky for maybe some sensory reasons or something else. So
yeah, you bring up a good point, because I think, we're quick to jump to medical interventions or swallow studies when a speech language pathologist can take a quick look at it and rule out 99% of those things, and what areas that we still need to rule out or have more assessments on, versus just jumping into a feeding tube or some other large, drastic medical intervention.
Which it speaks to that good communication between the referring provider and the therapist. Yeah. Whether that be Peds GI or the primary care provider, and or all three, kind of having that conversation. Like, you're seeing this, and then that informs what we, as either the primary provider or the other specialist. And that could also involve neurology or whoever, because there's some complicated kids that have multiple things going on. But that communication is key, and having again all those different eyes looking at it sort of from their own lens, and then coming to a good cohesive sort of
we don't have that really in Montana, where other big larger cities have that whole team effect in one facility. In ours, we have such great providers, but connecting the dots, like you said, is sometimes
we're not all at the same place at the same time.
Right.
Even though we wish we could be, but it doesn't always work that way.
Communication binders are huge in our facility. We try to get the parents using those and sending those back and forth to the professionals, because sometimes you need that information handy and right away.
And so I think with some of these things too, I wanted to chat about what you thought about things like food introduction, which is a huge, again, also in your wheelhouse, and how foods should be introduced. And then there's this whole concept of baby-led weaning.
Yeah.
So I'd love to get your take on it, especially in light of like experience,
Right.
personal experience as well as
Yes, my
professional
little one.
experience. Yes.
Yeah, my little one just going through it. I mean, I think every kid is so different, and that my child, who's now 6 months, actually 7 yesterday, I think it's so important to just be able to read your kid and just, go with your gut, so to speak. As a parent, you know what's going to work and what doesn't work. You use the guidelines. But I think a blend of a lot of different things that are out there, baby-led weaning to just basic purees, starting with the developmental hierarchy on those easy foods and having them have the consumption or the calories that are important too, and what kinds of foods are in there. Our favorite is solid starts. Mm-hmm. That's easy for parents to follow right along with. But yeah, I mean, you have to read your kid. Like my kid, for example, we started purees and then started table foods because she was really, really interested at a young age, 4 or 5 months. But her GI just wasn't ready for it. She just didn't tolerate it. She was up at night and screaming because she couldn't process that yet from a GI standpoint.
She could process it from the oral motor
Yep.
and chewing and swallowing.
Chewing, swallowing, she loved it. She loved
but
the
then her
taste.
intestines were like,
right.
not so quick. Or microbiome or whatever it was.
Exactly. So if we did baby-led weaning just by itself, I think it would have been a little bit of a struggle.
So describe it a little bit more, because
Yeah.
our audience may or may not know what the baby-led weaning kind of movement or concept is.
Right. So you're basically taking whole foods and letting them break apart pieces as they are able. So it's kind of a backwards down approach or top down approach, I think of it as. So you're letting the baby develop the shifting of their tongue using, maybe a piece of steak versus introducing purees at that age. So they're learning those skills and breaking up pieces as they develop more of their mechanical skills. Mm-hmm. Which is great for developing those skills. So I think there can be a blend, but as far as calorie consumption and nutrition wise, I think, in my opinion, there needs to be a little bit of a blend.
That's the conclusion I came to as well.
Right.
Like
Answer.
when I wrote the Feeding Our Children book, I was like, oh, these are great, but the purely baby-led weaning, they actually seem to be a little lower on some of the proteins.
Sure.
And nutritionally, I think honestly, meat or meat or salmon or some of these things are like great early foods. Eggs is great to start early on, because the two things that breast milk are low in are zinc and iron by design, but it also lends you to think like that those should be in some of the early introduced foods. So having some of those type of things early on, which, like what we used to do is we'd slow cook like a roast until you can just shred it apart and then mince it down. Not necessarily puree it, but just so that it's like just melt in your mouth kind of things. But we would also puree like chicken thighs and mix that with a veggie, and so we weren't hardcore going baby-led weaning, but we would try to do some other things where they had to work their mouth a little bit, because the disadvantage with purees is no
Just swallow
work,
it.
no work required.
Yes.
Which is great, because they're not less likely to choke on it. But and I'm actually going to talk to Reed Thompson on Thursday, who is a pediatric dentist, and there's a lot we're discovering about that lack of sort of chewing challenge early on, and underdevelopment of the mouth, the whole oral cavity, and then that having all these downstream implications. So it's pretty fascinating thing. So that's why I think it's having some good guidance, and just like don't start them out on Dr. Pepper and Cheetos, like for a host of reasons. But
even straight baby food, that purees, there's not a lot of calories, in those things. So I think a blend, like you were saying, some of those early table foods are important as well.
Because I was wondering too, and not to again be judgy or anything, but I think that maybe not having as much guidance and the lack of introduction of a variety of foods at the right pace, like how much does that imprint upon that child that then makes it harder to offer them foods later on?
Yeah. I
don't know what your take is on that. Again, not to stir the pot.
I don't know. I mean, it's interesting. I mean, there is that window, they say, between 4 and 6 months that we're introducing. And so, what types of foods are we introducing and when? I think definitely has a role in it. I think there's so many variables, but, ignore those pieces as well. So
at what age do you think, like, would it be an alarm bell for you if they're not really tolerating any solids or interested in any any sort of solid type foods? By what age would you be like, this is somebody who should probably, potentially get a consult with a speech
yeah, I would
therapist,
say for
feeding
sure by
therapist?
8 months in my book, because then most kids are at least interested and at least trying to take in something around that 6-month mark. So waiting till closer to 12 months, I think, is a little bit too long, because then you're trying to reverse everything that's going on.
And I've had kids where they've been like 2.
Yeah.
And then I refer them over, and
Yeah.
there's a road back, but it's a long road back, right?
Yeah.
Because some of those, again, imprinting and neurodevelopmental feeding stages, that if you miss that window, it's just hard to, or these kids who are tube fed, had a G tube in for very valid reasons.
Yep.
But that's a whole nother, I'd say that's probably the most challenging thing that sometimes that your profession faces, is the G tube weaning protocols, and trying to get kids back onto a regular diet from who've been tube fed for so long,
Right.
so other medical things. So.
Right.
Which is a whole nother, I think, sub area of pediatric feeding disorders, or kids with major cardiac issues or lung issues or things like that ended up having a lot of medical interventions early, surgeries, may have had breathing tubes in and feeding tubes in, things like that, and then all that manipulation affects things,
Right.
and I think that's just so important to get plugged in with, probably speech, OT, PT, all those therapies early on, to really try to help that comeback trail.
Right.
And
Yeah, I
access
think
can be an issue, but boy, I think it's so crucial.
just at least getting some correlation between positive oral experiences, even if it's not direct therapy, I think is very important. I know there's a lot going on at that moment for that parent, just dealing with all the medical appointments and medical interventions. But yeah, just having some tools or some resources at that age, or just to have in your back pocket, so that when you're ready to kind of implement, those things are important. And kind of going back to, the feeding, waiting a certain point, I think it's just important to ask the parents, like the parent knows if they're kind of seeing some signs, and just go with your gut. I think that's the biggest thing. Speaking of gut.
Yeah. No, I agree. And there's something's not quite right.
Right.
And there are, I think the Feeding Matters and some of these other organizations are really there trying to champion getting the word out of these early recognition. If there's something not quite right, talk to their primary provider. They may or may not be fairly well versed in sort of the signs and symptoms and the alarm bells. But, if you go on the website, I don't know if you guys have anything on yours, but certainly on the Feeding Matters website, there's kind of little questionnaires you can do.
Sure.
And sort of figure out is my child potentially at risk for one of these things or showing some signs? And I was if there's any question, it never hurts to get evaluated.
Right.
And, even though, we're in Montana, but there's a lot of good therapists
Absolutely.
around there, not in every nook and cranny, but, we're pretty lucky in the Valley. I think there's a bunch of good therapists. And I mean, obviously, there might be a little bit of a wait to get in or whatever, but if somebody needs to get in, usually I know they've...
The feeding ones, for sure, we prioritize.
Yep. So how about ARFID as a subsection? This is the, I don't want to say the hot diagnosis or whatever, but it's certainly kind of really come into a little bit more of the public consciousness. But so what is ARFID?
Gosh, it's the avoidant, I don't know the exact...
Avoidant
restrictive
food intake disorder.
Yeah. I don't know. Fancy terms.
Yeah.
I guess I'm too old school for a lot of
this stuff. There's actually a diagnostic
but...
code for it now,
I
so
know.
that somebody deemed it worthy,
Yeah, I mean, I guess I'm old school in a lot of that stuff, dyslexia, ARFID, fancy terms for what we already do. But again, going back to what is the root there? Is there a psychological component that we have to address some of the anxiety types of things and refer out? Or is it sensory? Or what is the underlying culprit, I think, is the most important thing that we don't always talk about. But
because these are super picky eaters, right?
Right.
There's sometimes literally 3 or 4 foods, and that's it. And they don't tend to be health foods.
Right. Exactly. Exactly. And usually they're obviously older kiddos that have been going through this a long time. So again, is it just a fancy term for what we see on a day-to-day basis with the majority of our kids, which are, 2 to 8. But, not trying to discredit that it is sometimes more of a complex issue going on. And I think it's just important, again, like you had mentioned, to get all team members involved, if we're trying to rule out another component to what's going on.
Yeah. Yeah, because I've had kids who sort of develop this avoidant restrictive food intake disorder, really limited diet, because they had this eosinophilic esophagitis or EOE, or because there was something else going on, and really so many foods actually literally hurt their stomach that then they self-restricted. But then there's other ones where we do the workup and end up doing endoscopy, rule out all these other things, like their GI tract looks pristine, and then we start thinking, okay, and then we are like, we ruled out all these other things, and now we need to check swallowing mechanics, and is there just, again, one of these sensory things that somehow wired them to, because then with a lot of these disorders, everything is too something, like it's too green, it's too slimy, it's too, they tend to really accept crunchy and hyper palatable, like snack foods. Chicken nuggets are almost always on the menu.
Chips. A bland orange or beige color, dry crunchy are the go-tos. Those are, classic.
But green foods are verboten. It's like, and again, there's a path back, but if you have a really super picky child, I think it's, I wouldn't just blow it off, because I think long term it's going to do them, at the very least, a nutritional disservice, and there can be real ramifications, like true nutritional deficiencies that end up hurting their immune system, or hurting their brain development, or things like that. So I'm always a proponent of act early, and again, you're not going to make advancements if you don't seek the help to kind of navigate you through that, because it's to do it solo is pretty difficult.
Yeah. And in those older ones, it's harder because they know and they can verbalize exactly why they don't like that food. And so your mind just goes right to, it's a behavioral issue. And 9 times out of 10, there was or is a root cause to it, but they might not be able to verbalize what's going on. So
yeah. And again, work with other providers too. Again, I think if there's a significant feeding disorder involving a pediatric gastroenterologist, involving obviously the primary care provider, involving I'd say most of the time, again, here it's speech, but sometimes OT if they happen to be more in their region, the ones who are doing more of the feeding therapy, and then really get that cohesive diagnostic, I guess, acumen all put together to try to figure out what's the best route out for that particular child. Because there's people who've waited for years, and then again, the longer you wait, I think the harder the road is out.
Yeah, absolutely.
What are the resources? I know like the Feeding Matters is the one that comes to my mind as far as like a good kind of resource, but are there other resources that you can think of for if parents are curious or concerned?
The Pediatric SLP on Instagram too is a good one. We do all of our therapists at some point get a special certification through SOS, so that's through the STAR Institute, and so it's on sensory integration matched with feeding basically. And so they have a lot of good parent courses on there too, or resources on their webpage as well, so we direct parents to there.
Okay.
Yeah,
because I know, like I said, not everybody lives in an area where there's immediate access, but it's certainly in Montana, all the bigger towns should have available therapists, and when I was traveling around, I would always try to find out who the local ones were that I could refer to, but it seems like once people start figuring it out, everybody they fill up, but it's good. I mean, I think there's still access, and they're enormously helpful if there's anything going on from like kind of the feeding perspective, or I mean, for that matter, the speech perspective, which isn't as much in my, in my conscious
It's
whatever.
the next wave, you got to get the
Eating and
going.
pooping.
Yes.
Eating and pooping. That's
got to get that going first,
yeah.
and then you can address the speech stuff. It's definitely a priority. But yeah, we have teletherapy too. Like I see one still over in Great Falls and have been for a couple years now. So we have so many tools now that we can access so many places. So just find a good fit and ask lots of questions, even if it's, like I said, not direct therapy, just having, a resource or an evaluation to say, hey, this is the direction that I would recommend, or some tools to keep working on things. We've done that with a lot of parents, even just locally here. So
cool. Yeah. So I guess if you had a couple pieces of advice for parents as a speech language pathologist, I know that's a huge sort of put you on the spot type of question, but things you think like every parent should know or maybe be aware of. Oh. And that could reiterate things we just talked about.
Early intervention is just so important, because all of our skills, whether it's speech or feeding, they say, if we can get them caught up by 4, we don't have to play catch up for the rest of their life. And work on compensatory strategies. So before 4, and give us time to work on that before 4, not at 4.
It's not instant. Yes.
So even, babies, if you want to pop them in or call for, free consult, those type of things, we don't mind. We'd rather be a resource than see them after 4.
Okay. That's good. Yes. Don't wait.
Yes.
So yeah, what are the best ways to get a hold of you?
You can look us up on our website, mtbeginnings.com, or email, or give us a call. We have 3 locations, the Eureka and Columbia Falls and Kalispell locations. Info@mtbeginnings.com is the easiest way to reach out.
And are you on socials at all for you guys personally? Or?
Instagram and Facebook, although we get busy, so we don't always post on there,
yeah.
But you can follow along. We've got lots of free events, and like I said, if you need a consult, just give us a call. We do free screenings for daycares as well, so we have been in multiple daycares doing those screenings for early interventions.
Oh, great.
So I think we did one of those years we did probably 300 screenings
wow.
in the fall. Yeah. So luckily not a lot of kids.
But that's a great service though. It's
yeah,
a good captive audience and
yep.
yeah.
Yeah. So if you have a daycare or preschool, we'd happy to come and check your kids out. Or parents can just give us a call.
Spy on them while they're eating.
Right. Exactly. Or have a snack with them.
Yeah, there you go.
Best part of therapy.
Yep. All right. Well, I know you have a bit of a hard stop because you need to go pick up your kiddo, speaking of which, from daycare. So thanks so much for being here. And,
thank you.
Hopefully people found this interesting. And again, if you have any other questions, you can also reach us over here at Functional Medicine Associates. Our number 406-501-6570, functionalmedassociates.com. And if you are getting good information from this podcast, like it, share it. If you know somebody who could benefit from this information, please share the podcast with them, help us grow it. And we will see you for the next episode, which I think, again, is probably going to be on pediatric dentistry.
Nice.
All right.
Excellent.
Take care,
Thanks
everybody.
for having me.
Thank you.
Bye.